Excellent. So thank you everyone for attending this afternoon. It's our pleasure to announce that Dr. Liz Whittaker, who is a professor of practice for paediatric infectious diseases and immunology at Imperial College London. She is also the clinical lead of paediatric infectious diseases and the co-lead for the high consequence infectious diseases at St. Mary's at Imperial College Healthcare NHS Trust. Dr. Whittaker is also the Director of Research for the West London Children's Healthcare, working closely with the board of the West London Children's Healthcare and Imperial College Centre of Paediatrics and Child Health to ensure research is embedded in every patient's journey. She is the National Clinical Lead for High Consequence Infectious Diseases in Children for NHS England nationally. And today is kindly given us a talk on an overview of vaccination for patients with sickle cell, including addressing vaccine confidence. So with that, I will hand it over to Liz.
Thanks very much. So I'm Liz Whittaker. I'm basically I've pulled together some slides. I do a lot of teaching on vaccines, both at Imperial College for the BScs and the MScs, but also just locally with a variety of different people. So apologies if I'm oversimplifying things or talking too fast. I am Irish and do have the gift of the gab, but there should be time to chat at the end. And hopefully this will just be an up-to-date reminder of what vaccines we use for sickle cell disease and why. Hopefully you can see my slides okay. Yeah, brilliant. Okay, so vaccination is pretty extraordinary and we are extremely fortunate to have it. And I think this has led to one of the things that causes a problem from a vaccine confidence perspective is that there is complacency because people no longer see the infections that have been prevented. And on the right here in this lovely rainbow graph, what it is showing to you is how many years of life have been saved due to vaccination from a variety of pathogens, with measles in yellow and various other pathogens going down below over the last 50 years. And this is a great paper if you want to go and have a look, which just shows us in real numbers what the impact of vaccination has been. And I think we don't want to lose hold of that. Now, I'm not going to go through all of these key concepts, and I'm very happy to share my slides. And I think it's just that understanding of what are vaccines and what do they do, and fundamentally it's anything that promotes a protective immune response in the child. And I think this picture here on the right, where you get a very similar immune response, so you have a disease-causing organism, you get the disease, which has a variety of different outcomes. So many people may recover completely, but unfortunately there is always a risk of death or disability. But with survival you get immune memory, and the magic of a vaccine is that without taking on the risks of death and disability, you can get the same or sometimes a better immune response, immune memory response. And so lots of different types of vaccines exist. And I just also wanted to introduce some different concept, which is that we're, this is active immunity that I'm talking about here. And more recently, in particular with the RSV, the monoclonal antibodies that we're giving to preterm infants, we're talking about passive immunity. But also when we vaccinate mums, we're talking about passive immunity to the baby. And so vaccination has become broader and covers not just that active giving of a substance to promote immune response, but sometimes we give some passive antibody as well. And the world has come a long way since Edward Jenner developed a smallpox vaccine, but even he faced challenges in terms of vaccine hesitancy and people thinking he was trying to do harm, when actual fact this is the one organism that we have eradicated completely. Most of what we've developed in terms of vaccines has actually happened in the last 80 years with diphtheria, polio, etc., measles, and then the last 20 years have been extremely productive, and even more so when we take into account the COVID vaccines and the RSV vaccines, which I just mentioned. So really exciting time from a vaccine perspective with huge advances protecting people. This is the one paper, if you just want to remind yourself about vaccinology. Andy Pollard, who is a professor at Oxford and I don't know, he's Lord Sir Andy Pollard or something, just a great guy who's written this really accessible paper about vaccines and thus showing the efficacy of a variety of the pathogens that we protect against regularly, such as, this is just showing you how many cases there were, the vaccine is introduced, the bug goes away, and you can see this pattern for polio, diphtheria, measles. Pertussis has a little blip because of some changes in the vaccine schedule, and then some bacterial infections such as MenC, which is another huge success story from our perspective. And this is just more telling you about different types of vaccines, which I'll talk about in more detail as I talk about different pathogens. And the whole concept of this is about the fact that we develop immune memory, and it is different in different ages. And one of the things that is very interesting to me that I do research on is why infants have different immune responses, and why our vaccine schedule looks as it is. So we are trying to give vaccines to very young babies who respond differently and create memory in a different way. And that is the reason why we end up giving multiple doses of a vaccine in that age group. If we were to vaccinate an adult for the first time with one of those vaccines, we often can get away with 1 or maybe 2 doses rather than having to give 5. And so it's just being aware that we use vaccines in different age groups differently because the immune response is different. But also sometimes we need to do boosters for things. And that might be one of the things whereby if you are working in the NHS and you haven't had a pertussis vaccine in the last 5 years, you should probably get in touch with occupational health and have one, because that is a waning vaccine and there is lots of pertussis around at the moment, for example. And so it's just being aware that sometimes immune responses need boosting, and that is no bad thing. So you will probably have had your Hep B titers checked when you became a healthcare professional, and sometimes you might be offered a booster for that as well. And then finally, just one more concept from a vaccine perspective is that of herd immunity, which is this just showing you in colour how if there's no vaccine and one infected person, if one person becomes infected, then actually the risk is for many people to become infected. If there's vaccine protection in the community, those people who cannot be protected by vaccination are protected by everybody else who is vaccinated. And this is particularly relevant, I think, for some of the cohort we're talking about in sickle cell who are asplenic and may struggle to respond to vaccines in different ways. And so why is it that that sickle cell disease increases infection risk? Now, I'm not going to pretend that I know as much about this as the audience I'm talking to, but fundamentally the main reason is because of splenic dysfunction. And this is because of repeated damage to the spleen. Often you end up with either functional asplenia or hyposplenia, and it's really hard to measure splenic function, and so we sometimes make assumptions about how asplenic somebody is or how functional, how much function has been lost. But actually sickle cell, as you know better than me, is a chronic inflammatory condition, and this immune dysregulation and changes to the endothelium and various other things actually also creates an immune susceptibility, particularly to bacteria, but also to other infections, which makes patients with sickle cell disease more vulnerable to infections. And in particular from the spleen, we know that the spleen is particularly important, working with the complement pathway to take out encapsulated bacteria like Streptococcus, Haemophilus and Meningococcus. So I'll spend a bit of time talking about those vaccines today. But actually they are, patients with sickle cell are at higher risk for other serious infections, including flu and COVID and hepatitis B in particular. So this is a vaccine that your patient population should be offered. And these are the common infections. This is from a figure, just you'll be familiar. So everybody thinks, I think, of pneumonia, but actually they are, and our population are very susceptible to other infections, including osteomyelitis. And if we look at which of those are vaccine preventable, very importantly, those causing brain infections, bad pneumonias, some of these viral infections here, and then also just bacteremia, which of course can contribute to osteomyelitis and septic arthritis as well. We are working on malaria vaccines, but we're not quite there, and I'm not going to talk about that today. So this is a figure of the UK vaccine schedule. I've put in italics oral polio and Hep B because your patients may have been born overseas, or if the mum has a Hep B infection, they will be offered a birth dose. BCG is actually given after this time now, but ideally is given in early life before they start having their routine immunisations. And I'm not going to lie, the UK vaccine schedule changes quite regularly and has changed quite recently. So don't be surprised if you look at this and think, oh God, I didn't know that. So we're currently giving different numbers of these vaccines. So we have the 6-in-1, which is diphtheria, tetanus, polio, pertussis, Haemophilus and Hep B, alongside a couple of other vaccines. And this is pretty standard, apart from the Hep B, internationally in terms of what we give. And then we tend to give measles and mumps and rubella after a year of age. And then you also offer some vaccines in secondary school. So for sickle cell, it is much the same, except for in addition, they get more pneumococcal polysaccharide vaccines. That's the PPV23, which is a different type of vaccine. I'll give you more information. And then that should be given again every 5 years. MenACWY, which is normally given to adolescents in year 9, depending on the age of diagnosis of sickle, may be given in the first or the second year of life, or whenever the patient is diagnosed, when we think the spleen is at risk. And then finally, influenza and COVID should be offered from 6 months every year. And that is current up-to-date guidance. And I will talk about these in more detail. So Haemophilus influenza type B, hopefully many people have never seen the disease, so it has traditionally caused quite significant bacterial meningitis, pneumonia, and epiglottitis. That is a very blurry picture, but this is showing you this massively swollen epiglottis, which has a really high mortality rate because it blocks the airway, but also a common cause of periorbital cellulitis, which can all be managed with antibiotics. Actually, the use of steroids for bacterial meningitis, the evidence for that is predominantly from Haemophilus, and the magic thing is that actually since we started vaccinating, that becomes a little bit obsolete. What is not surprising is that most Haemophilus causes death across sub-Saharan Africa, where many of your patients may come from, and so there may be family members who've been susceptible to this. However, we have been vaccinating for some time with a protein polysaccharide conjugate vaccine, and these have been a real game changer for paediatric vaccines. So I mentioned earlier that infants respond differently to vaccine to older children. By adding in a carrier protein to an adjuvant to the whatever part of the bacteria that you're trying, or whatever the part of the bug that you're trying to pass on, you help to promote an immune response in that infant, which they're able to respond to. And we've been using this for some time. It often comes as a combination. We started using it in the 1990s. We realized that we probably needed to give a catch-up routine at this point in the 2000s, but we can see that since then, actually, it's quite uncommon that we see Haemophilus. We see non-typable Haemophilus in neonates, but really don't see Haemophilus influenza B outside of that period. And so they get 3 doses in the first year of life and a booster at a year. This is what it's going to look like when I tell you about the schedule going forward. Neisseria meningitidis, so this is a diplococci, which we are all terrified of. I've got to be honest, I think that everybody worries about this bacteria, and there are a number of serogroups, and the most common ones that we used to see problems with were B and then C. We had a vaccine against C first, and this causes meningococcal sepsis. So this is purpura that you can see in the image, but can also cause meningitis. And meningococcal sepsis is rapidly spreading, starts off with petechiae and purpura, and then they develop overwhelming sepsis, which can be really difficult to treat, with the sequelae of limb loss and brain damage. And actually, the reason that the MenB vaccine got into the schedule was because of the health economic modelling on both the impact of admissions, but also the lifelong disability associated with this horrible condition. The management is antibiotics. It's supremely susceptible to penicillin, and obviously access to supportive care. And so different outcomes in different places. And this is just showing you that in a pre-vaccine era for MenB, most cases were caused by MenB vaccine. It was very exciting when in 2015 this was offered to all babies. And we have a series of different vaccines. So Bexsero is the most recent MenB vaccine that's in the schedule. And initially there were a protein, the Group B meningococcal vaccine is a different type of vaccine. It's done through reverse engineering, but we also have a conjugate vaccine against Men-C and Men-ACWY. So different types of vaccines for different types of meningococcus. And again, you can just see that Men-C, we really just don't see anymore, thankfully. It seems to be more or less eradicated. The Green Book is the place to go to get information about vaccines, and Chapter 25 will tell you more about it. And what you can see is this B disappearing after introduction in 2015, with a bit of a recent resurgence. And this is predominantly affects babies under a year of age, and very rarely causes problems in older adolescents. In older adolescents, we tend to see disease with vaccine serotypes W and Y. and sometimes with A, but Men-A tends to happen across the sub-Saharan belt as well. So if you travel to that part of the world and you've not had a meningococcal vaccine, it is one of the vaccines that's recommended. And so we now currently are giving no Men-C doses at all because we're not seeing any cases, but babies get 2 doses, I think at 2 and 3 months, and a booster at a year. And then we're still vaccinating adolescents with Men-ACWY. And I realize I didn't put it in here, but obviously for the Men-ACWY, we are giving that at a younger age to children with sickle cell disease. Apologies for missing that out. So strep pneumo is a bacterial pathogen that causes massive problems, gram-positive cocci in clusters, and this is just a growing group on a strep viridans, on a blood agar plate. Sorry, I can't speak micro today, apologies. And what we're seeing here is it's a common cause of otitis media, pneumonia. We can see here is osteomyelitis, sepsis, meningitis, all sorts of horrible infections. So strep pneumo is a huge pathogen causing complex bacterial infections in children and adults. So this is something that is a problem across all the spectrum. And we initially had a polysaccharide vaccine, which is the 23-valent vaccine here called Pneumovax, which is what we had. This doesn't promote very good immune responses in young children, and so it wasn't really offered to young children because it involves both T cell and B cell interaction to respond. And then we have Prevnar 13, which is a more recent vaccine, which is conjugated with CRIM, and from this we now get much better responses. And so this is the polysaccharide. So we give Prevnar 13, which has got 13 different serotypes, to children in the first years of life. And then we use the polysaccharide vaccine once they're over the age of 2. It's also offered to adults. And interestingly, or worryingly, I think that we're seeing increasing numbers of cases over time. So this is 24, 25 in children under 2, and you can see that trend is lower than it was in 2022, 23, but higher than it had been in other years. So these case numbers, though, are relatively low compared to what they were prior to vaccination. And we can see that's the same for older children. But what we can see is an increase in replacement strains. So this is looking at the numbers of cases in non-PCV13 vaccine strains. So one of the things that we see is escape and replacement. And so there are a variety of other conjugate pneumococcal vaccines. So we've got Prevnar 13 and Prevnar 20, which might become part of the schedule. They are available to prescribe for some patients, not used very routinely, occasionally given to children who've had cochlear implants. But we do use the PCV13. And so this is just a study looking at pneumococcal pneumonia in adults. And I think this is relevant because hopefully all of our patients are going to become adults. And what you can see is that it's still a really common cause of hospitalized pneumonia in adults, pneumococcus, despite vaccination, and only a third are covered by PCV13. And so it is something to be aware of, that we do need to consider whether we move to a more multivalent pneumococcal vaccine over time. And so children, because of the decrease in the success story of pneumococcus after introduction in 2008, we've now moved to what's called a 1+1 regime. Some of us are uncomfortable about that because we think that it should be, in many other countries, they do a 2+1 regime where they give 2 doses and then a top-up dose at a year. But we're looking at cases to see if there's an increase over time, and so far that doesn't seem to have happened. And then for children with sickle cell, they get offered a polysaccharide vaccine at 2 years and every 5 years after that. I suspect that the JCVI will review pneumococcal vaccination if we start to offer the PCV20 at some point, and it may be that we increase the valency of pneumococcal vaccine that's offered to our patient population. And this is just showing you what uptake is like. So it's about 58% of individuals who are who can have it are covered, which is about 28% of an annual basis who are asplenia, which would be this cohort, and there's a slightly higher preponderance for women to have it compared to men, or for females to take it, which is not uncommon with preventative measures for health by gender. Hepatitis B, I mentioned. This is a DNA virus which causes jaundice, and the worry is that you can get chronic liver disease and ultimately hepatocellular carcinoma, which is what's shown over here. And this is more likely to progress in patients with sickle disease, presumably because of chronic inflammation. So really important that we're testing for Hep B in our cohort, or vaccinating them to protect them. And this is a particle-driven vaccine, so it's a inactivated type of vaccine, and it is now in our national schedule. And also should be offered to at-risk older individuals who haven't had it. So if you've got older teenagers in your group who have not had a Hep B vaccine, this will be a good one to check their status by doing the serology and offering them Hep B vaccination to make sure they're protected. And so for babies, they get 3 doses in the first year of life. If the mum has a viremia and is positive during pregnancy, they may get a birth dose in addition. And I'm sure we all remember being the neonatal SHO and trying to understand what we're meant to be doing. Very briefly mention Hep B, and I partly mentioned this because of the chat about vaccine confidence we might have at the end, because this is one that many people have hesitancy about, and particularly in some communities there are different reasons why people feel that abstinence should be enough to protect you from Hep B, human papillomavirus, or cervical or vaginal warts. And so this is the wart virus, which can cause lesions in the throat. It can cause lesions pretty much anywhere, but the worry is that for certain serotypes, having lesions on the cervix can predispose or increase the likelihood of cervical cancer. And this is about 16 and 18. And really excitingly, there have been a number of advances in terms of these subunit vaccines, which are given initially. They were introduced for girls in 2008 and boys in 2018 to decrease the risk of transmission, but also to decrease the risk of disease for boys, both for oral and throat cancers and penile cancers. And this is just to show you how this has had a massive impact on cancer levels by introducing this into the UK. And this is going to be a real game changer for cervical cancer, in particular in women. So it's just from the World in data. So flu, I'm sure that all of your patients don't believe in the flu vaccine. Most of my patients don't. But influenza can be really nasty. I don't need to tell you that. Can cause really nasty respiratory disease, or actually what we see in children is gastroenteritis, and then worryingly encephalitis and even necrotizing encephalitis disease. So it can be really nasty. Then the other big thing that's a problem is secondary bacterial infections. And so with group A strep in 2022, we saw massive outbreaks of group A strep infection, but we also see staphylococcal infection. Now, if you go back to that picture I showed you of the infections that young people with sickle cell are at risk of bacterial infection, it was very clear on there. And so we know that for patients with sickle cell, they're both at risk of more severe influenza, but also particular risk of secondary bacterial infection following viral infection. These should be offered on an annual basis. There are 2 types. There's an injection, which is inactivated, and then there's the live attenuated influenza vaccine, which is nasal. It has some gelatin in it. So for some patient populations, they may be reluctant to have it. And for sickle cell patients, they are eligible for either type of vaccine. So if they don't want to have the sniff vaccine through school, they should be offered an inactivated vaccine. And it is part of our national schedule for all children between the ages of 2 and 16. And so they should be offered in school, but we should in addition be doing our best to make sure that our current patient population are also offered it. I've put in COVID here. Again, I'm sure that nobody's forgotten that COVID causes severe pneumonia, but in children it also causes PIMS or MIS-C, which is this post-infection inflammatory syndrome. There's a series of studies showing that patients with sickle cell are increased risk of severe disease with COVID, predominantly really because of associated comorbidities rather than the underlying sickle. So this is probably older patients who have renal disease or have had lung disease. However, this registry of children with sickle and COVID showed an increased hospital admission compared to the patient population, both with severe COVID and PIMS. So I think that they would be should be sensible to consider COVID vaccination. At the moment, this is offered annually to patients with sickle cell of any age. There are two main mRNA vaccines, and these are really exciting developments whereby you introduce a little bit of mRNA, which produces a protein, and then the body responds to it. And these are just very exciting types of vaccines because they seem to be very effective and very safe. And also, one of the things that's very nice about them is that it's very easy to change the mRNA in them very quickly. So this is one of the reasons why you could respond rapidly to changes in the variant of COVID that was a variant. And so this is this year's JCVI statement about who should have what. And what you can see is that both for under and over 16-year-olds, those with asthenia who have sickle cell disease are recommended to have a COVID vaccine, and we should probably be offering that. So this is just a reminder of the vaccine schedule for those patients. I am talking very fast, so plenty of time for questions, sorry. I just wanted to mention travel health because we've just had September, and I know that a lot of our patient population may visit friends and family overseas in exciting and tropical places. So it's always good to have an update on what we should recommend from a travel perspective. Patients with sickle cell are at increase of complications due to their underlying condition and can take some measures to protect against that. They should also just be aware that they need to make sure they take their penicillin, but consider actually having a low threshold for other antibiotics to take with them. This is some recommendations from national guidance. But also that there are travel vaccines that they may be eligible for. Now, just for the clinicians on the line, the Hospital for Tropical Diseases in London, which is based near UCL, has a referral pathway. And this is a really good place to refer your patients for if they are traveling somewhere and you're not 100% sure what they need. So they're traveling to Guinea or Senegal, and you think that they might want to get some bit more detailed advice than going to Trail Finders. These guys are very happy to see patients like that. I'm also trying to arrange for Nikki Longley, who runs the clinic at the Hospital for Tropical Diseases, to come and do some ad hoc clinics with me at Imperial in May and June 2026, so that we might be able to do some travel advice locally. And I'm very happy to talk to anybody who might be interested in helping to co-arrange that. And that way we could either talk to people about what they should be getting and try and support them. We might even try and bring some vaccines with us to give in clinic, but that is slightly more complex. Everybody thinks that you don't get malaria if you have sickle. That's not true, and it can be serious. Oh, hello, and life-threatening. So all the usual protective measures in terms of insect repellents and prophylaxis, and don't forget to check for G6PD deficiency, but hopefully that's partly done as routine care. I thought I'd mention Hep A, which is another hepatitis, an RNA virus, unlike Hep B, which is a DNA virus, and this causes jaundice and a gastroenteritis, and there is a vaccine available that we should be offering to anybody who's travelling to anywhere interesting at all. I consider some parts of Eastern European in this interesting. I'm going to mention typhoid because we've had a couple of cases of severe salmonella in returning patients with sickle cell recently. So Salmonella typhi is the pathogen that causes typhoids. It can also be Salmonella paratyphi, and just as a caveat, that is not covered by the typhoid vaccines. We've also seen non-typable Salmonella, which are the cousins of this, which can cause quite severe disease in patients with sickle, either whether it's contracted in the UK or overseas, and again, that's not protected by this vaccine. And so this is one of the pathogens that can be quite significant for patients with sickle that we think about quite a lot. Is usually covered by ceftriaxone for non-typable Salmonella, and they tend to, you never see the rose spots, but we all want to. They have this history of fever with a relative bradycardia. Again, that's actually quite hard to spot, but the worrying thing is they get quite significant intestinal inflammation and perforation. It can cause osteomyelitis, meningitis, liver dysfunction, and all sorts, and has quite a high fatality rate. We are seeing increasing antibiotic resistance, particularly from patients who contract their typhoid in Pakistan, but also there is some resistance across some of sub-Saharan Africa. So it's just worth liaising both with micro and the PEDS ID team if you have a patient with typhoid. There are a couple of there are 3 different types of typhoid vaccine: a polysaccharide vaccine, a live attenuated vaccine, and there is a conjugate vaccine which is available in some countries. The efficacy varies, and part of that is because of the type of vaccine that there is, and part of it is because a lot of it's caused by Salmonella paratyphi. They're not recommended or very efficacious in young children, so this would be for your older cohort, but anybody over 2 can access a typhoid vaccine in our country, and the live attenuated is available for those over 5. Yellow fever comes up quite a lot for patients who are traveling in particular to Africa or South America. It is a flavivirus. It can be really nasty. It's not quite as bad as some of the flaviviruses, but it is the one that's most commonly recognized. So this is a mosquito transmitted infection, and we can see here that it causes really significant and life-threatening, potentially jaundice and meningitis as well. So this is the Aedes mosquito, so you have to be in the right place to get it. A reasonable proportion develop severe disease, and many countries ask for a certificate of vaccination for entry into the country, particularly if you're traveling between different countries in the continent. So, for example, traveling from the Congo into Rwanda or something like that, you would need to have a certificate or a certificate of exemption. It is a live attenuated vaccine. We don't give it to very young children, and there is a reasonable risk of adverse reactions, particularly in the elderly, but this is one that we would recommend for sickle patients who are traveling to yellow fever zones, and this is another good vaccine to discuss with the Hospital for Tropical Diseases in terms of indications when not to give, etc., and just one to be aware of. So I'm going to talk a little bit about vaccine confidence. This is another paper that was published this year looking at vaccine coverage since 1980. I was going to say the last 20 years, but it's clearly the last 45 years, and I'm just completely losing my age. And the worry here is that we made amazing progress up until about 2015. But even before the pandemic, but definitely in the peri-pandemic era, we've seen a drop-off of vaccine coverage for pretty much all the vaccines that we offer. There was a little bit of recovery in 2022, but actually there's been a downtrend again since then. And this is really worrying. This is international, it's not just in the UK, and there are some concerns about whether or not we can recover, whether we'll continue on a trajectory which is going to have a low cover. So the 2 main metrics that people measure on a global scale is whether you have the 3-in-1, which is diphtheria, tetanus and polio, and that's a 3rd dose. Have you received 3 doses of your infant vaccines or 2 doses of measles? So they're the most common metrics we measure. And you can see from this forecasting that we're going to have to do quite a lot of work to get back into the zone of herd immunity for these pathogens, and that on the current trajectory, we're definitely going to not achieve herd immunity on a global scale. And more worryingly, it looks a little bit like we might be downtrending, and if that trend will continue, we're getting into complete dire straits from a vaccine perspective. So this is a really worrying time for those of us who recognise the value of vaccines. And there are millions of children on the globe who are unvaccinated or under-vaccinated, so they haven't had the full dose of vaccine schedules. And a lot of these are in places with poor resources, where there's conflict, where there's famine and drought and all the rest of that. One of these countries is India, but actually overall, it's just because India has massive populations. If you look at numbers alone, it doesn't work. You have to look at the percentage of the population to understand how big the problem is. So actually places like Mali and Niger do very badly, but they have a low population, so they don't spike onto that number zone. So it's just one of those things. Measles is one of the vaccines that has been hit particularly badly by vaccine confidence and vaccine hesitancy. And measles is a really nasty infection for everyone, let alone those with sickle cell. And so unvaccinated patients, if we took 1 infected person with measles and 100 unvaccinated patients, 90 of those people will get measles and 7 will get complications. It is extremely infectious. You only need a very short period of time with somebody to transmit it. And the worrying thing is that 4 days before they get their rash, they're infectious. So we really struggled with this when we had the outbreak last year, because children were coming to intensive care with coryza and fever and intensive care to ED with coryza and fever. They were exposing people and then coming back with the rash. And then the realization was that 250 people in the waiting room needed to be contacted because they'd been exposed to measles. So really problematic. This is a lovely paper in the New England Journal, which just goes through everything you'd ever want to know about measles and the vaccine. So I'm not going to go into that in great detail. But this year, noteworthy, the US took away all the money for Gavi that they normally provide. And so Gavi is the international company that helps to support low and middle income countries to deliver their vaccine programs. A lot of our outbreaks in previous years started in other places, like where there was war and political unrest, and then people travel around the globe and bring it to Europe and to the UK, and then we have low vaccine coverage, so it mixes very quickly. If we see that trend I showed you of dropping to 60%, then we're going to see increasing outbreaks every year of measles, and it is a really nasty condition. So this is just that then and now graph showing that we had lots of cases. We introduced the vaccine, the cases decreased, and we really, even though we talk about the outbreaks, the numbers are quite low in reality. This is just showing you that we had this big spike last year in 2024, which is really predominantly in London, that you can see here the number of cases. And this is in relation to the fact that our second dose of MMR coverage has just been dropping over time. And this is up to 2024, but that trend of falling has continued. And this is a real worry for us. And we live in a hotspot, so London is a bit of a disaster zone. Other highly populated areas in the Midlands and up around Manchester are also affected. And then obviously Wales is a very safe place to live. There are 2 MMR vaccines. It's always useful to have this information. But there is also a porcine-free version which has no gelatine in it, which is called Priorix. All primary care practices have access to both types of the MMR vaccines. Really importantly, it has no thiomersal. You may have heard that Robert Kennedy Jr. has agreed that the thiomersal is the problem for autism with vaccines, so there is no thiomersal in the MMR. These are questions that patients might ask you. The vaccine effectiveness is quite high, and a second dose really increases up to about 99%, but there will always be some people who don't respond or are not eligible to have a dose of the vaccine, and this is where herd immunity is particularly important for MMR, because it's for measles, because it's so infectious. I'm not going to do pertussis because I'll give some time to talk, but fundamentally pertussis rates have dropped. What I wanted to highlight is that the population who have the lowest uptake of pertussis vaccination and antenatal vaccination in particular is in their Black African communities, which I know is true. If you were to look at the ethnicity and the metrics for all vaccine uptake, the Black communities, Black and mixed communities, have the lowest vaccine uptake. And so we know that our population who are affected by sickle cell are more likely to be unvaccinated than any other population. So it's just something to bear in mind. So vaccine hesitancy is a term that's going out of favour. We would rather talk about vaccine confidence, but these are my historic slides, so I'm going to continue to call it vaccine hesitancy. And this refers to anybody who doesn't accept or refuses any of the vaccines despite them being offered. And that's a really important point, because sometimes low vaccine rates are because of challenges in accessing services rather than not wanting to have the vaccine. So there are 2 things that we need to consider to increase vaccine uptake across different populations. And it's really complicated. It's multifactorial. Different groups believe different things. And we talk about these things called complacency, convenience, and confidence, which I'll come back to in a minute. And it is this pyramid where there are very, very few patients who just refuse all vaccines. There are a reasonable number of people who delay some vaccines, and the MMR is often the one that people like to delay because of misunderstanding of risk. And then most people fall into this group where they actually take most of the vaccines but kind of feel slightly bad about it behind the scenes. And what we need to do is reassure this group and also try to reach this group with accurate information so they can make an evidence-based decision. So I mentioned complacency right at the beginning, and this is that idea that people no longer see children dying of measles, they don't see paralysed children because of polio, they're no longer seeing children coming in with pneumococcal meningitis, and so they don't really see the value of the vaccine because these infections are just childhood infections and their child will just sail through them, which hopefully most children would, but a significant proportion don't and have a significant morbidity and mortality. Convenience is a really big factor at the moment, particularly with poverty, people working 0-hour contracts, lack of community and support for families, lack of English as a first language, or challenges and barriers to accessing information or understanding how the system works. And then finally, there's confidence, which is this group of people who don't trust the vaccine or don't trust the government in particular, for some reason believe that the government would want to vaccinate for nefarious reasons, which obviously the government doesn't want to do that. This is just to demonstrate how people fall into those three categories. This is a study that was looking at why children didn't have the flu vaccine, and so this is just the convenience. I'll just put these in. So they kind of, though I meant to do it, but I haven't had time, or I couldn't get to the GP practice when it was open, or my daughter was out the day they did it in school. Then you have confidence, which is I don't trust the vaccine. And a lot of people talk about porcine products, and so a lot of work has been done to try and find alternatives. And some people feel, and it is a timing issue, that when you give the flu vaccine, their child always gets sick. Well, we always give the flu vaccine just at the beginning of the winter respiratory viral season. So I don't think it's the flu vaccine that makes people sick. I think it's a timing concern that they have it around the time that everyone gets an infection. And then there's the complacency, which is that my child will just build their own immune response by having the infection. So just to demonstrate what we mean by those three terms. And I said it varies in populations. So this is the human papillomavirus vaccination, where some people think it causes POTS. Some people are not happy that the trials were done ethically. In South America, they have these mass fainting episodes when they try to deliver it to children in school. And in the US, or in a lot of very conservative religious populations, there is a concern about promoting sex, and that they believe that you will only ever have one partner, and therefore you're not going to be at risk of getting HPV. We know that isn't always how things hang out. And what's become really interesting is that these used to be just in those places, but with social media and TikTok and Instagram, actually other people's concerns are very accessible when you go online and look. And so there are now multiple reasons why people don't want to take vaccines, because they've heard about the POTS and the narcolepsy and the various other things that other populations are worried about in different types. So the globalization and the access to internet actually just complicates the whole scenario. So what can we do about this? So one of the things that is true in nearly every study that we do is that parents say that they want to talk to a trusted person. And so healthcare providers often are the most trusted person to talk to somebody. And that's why it's so important that you, as the person who looks after a child or a young person with sickle cell, has access to accurate vaccine information and is able to have open conversations with parents about vaccines, particularly if they have unvaccinated patients, because people do trust us. They trust midwives and health visitors and GPs and neonatal nurses. And so I think one of my jobs is to make sure that we teach everyone about the vaccines. People are more likely to vaccinate if we're recommending the vaccine personally than if they get a piece of paper saying these are the vaccines you're going to do. And we need to make sure that we support vaccination of our colleagues. That's why I reminded you to get your pertussis booster. Why, if you're eligible for a vaccine, I would encourage you to go and have it, because you're more likely to then recommend vaccination to others if you have a positive experience and feel like they have benefited you. And that we provide capacity to healthcare providers so they have time to talk about these things to increase the confidence to patients. And I think that we need to give more support to healthcare providers. So this is a study that my colleagues did about the chickenpox vaccine, which is going to be introduced to the schedule in January, very excitingly. Actually, did you know that about 60% of paediatricians have been vaccinating their children against chickenpox for years? But actually understanding what people's understanding or knowing what people's understanding of the chickenpox was means that we can tailor information for paediatricians so they can talk to parents confidently about the chickenpox vaccine going forward. And so what we need to do is listen, really. What we do at a policy level is identify regions where there is low coverage, do work with local stakeholders to understand why, and then try and address some of those issues. So this is my PhD student who's now an ACL, Helen, who did this study working with women in West London to try and understand why they weren't vaccinated. And it's really interesting because this group, the Mosaic Community Trust, said, why did nobody ask us? And it's this really interesting question of, like, we make assumptions about why people don't vaccinate, but really we just need to go and find out why. So I'm not going to go through her study, but just to highlight again that you're much less likely to vaccinate if you come from a Black British or even community. And so we just need to be really wary of making sure that we're providing access. This is a report from the Royal College of Paediatrics and Child Health, and really interestingly, from a variety of studies, actually that convenience issue is a really big thing for many families. They struggle to book an appointment with the GP, or the GP only does vaccines on a Thursday, and that's the day they go to college or they work or they can't attend because their child is football or what have you. That more and more parents are working and struggle to get to appointments when they need to. That sometimes they're not delivering the vaccine in the local GP, and you've got to go to a specific place with no parking or it's difficult to get to. And I'm not going to go through this. I'm really happy to share, or you can go and have a look at this. But one of the other things that comes up a lot is about the fact that healthcare professionals didn't feel like they were able to talk confidently about vaccines and discuss potential side effects. And so this is something that we can address. So I think what was quite useful about this was it's not just all about the fact that everybody believes the MMR causes autism. That isn't the problem. The problem is that accessing vaccines is challenging because the systems we have are not working. Having a paper red book that you have to carry around is very 1980s, and we need to go to an online red book system and online notes and things like that because most people have a phone. I just wanted to talk about vaccine uptake and what we know about that in the sickle cell community. And what you can see from this poster that was in a conference is that actually in Cambridge they found a low vaccine uptake of the vaccines that all of these patients should have had. So the highest rate was 67% for PCV13, 75% for Hib and C. So really not reaching the level that we'd like to get to protect patients. I was really impressed and surprised about this, but that 85% of children in this group, and I got to say, I can't remember where this group is based, had their flu vaccine in 2020, but this had dropped to 75% after the pandemic. And I think that we know that the COVID pandemic really affected confidence in the vaccines, all vaccines. But of those 66 young people in this 220 who got flu, a quarter of them ended up hospitalized. So we do know this is an important vaccine to get people to have. And this is another study showing that young sickle patients are less likely than any other population to take on the COVID vaccine, even though, again, we know that COVID can cause severe disease and complications. So just in summary, from a vaccine confidence perspective, most people vaccinate, but some don't. And this can contribute to disease outbreaks. And what we really need to do is find the group. And I think that sickle cell populations may be a population who are less good at having vaccines than some others. So we have an onus on us to record vaccination uptake, and then work out how we can support our families to take it. And I think in terms of how you have those conversations, in my experience, most families are happy to talk about it. They don't want to feel judged. People make decisions because the information they have and because they want to do the right thing for their children. And so sometimes that might be because they haven't had access to very good information. It's really important to be honest. All vaccines have side effects, but most of these side effects are relatively limited. And it's very rare to get severe vaccine side effects. So it's more like 1 in a million. And that's often with children who we suspect have an underlying unusual response to any infection trigger. And so if they didn't have this overwhelming response to a vaccine, it might happen to an infection anyway. But still, there's nothing worse than as parents as knowing that you potentially caused harm by giving your child a vaccine. In reality, the harm from a vaccine is much less likely than the harm from the disease. And you should know where to get information. The Oxford Vaccine Knowledge Project, just a link here, has really accessible information for most families. Although one of the things that we've identified in the research we've done in West London is that written in English information isn't always the best way to access it for our families. And we're working on making a series of videos and little TikToks about vaccines and actually getting them translated into a variety of different languages. So if anyone is interested in working on that project, we'd be very grateful. on. And I just think I talked about this again at the beginning about how you get the same outcome whether you have infection or a vaccine. And the real thing is that whatever the side effects of the vaccines are, the side effects of the disease are always worse. And so I think it's really important to remind families about that. And I'm sorry, I've talked at you quite a lot for 50 minutes. May I take any questions?
Aini and then Debbie.
Hi, my name's Aini. I'm from Whittington Hospital. I'm one of the consultant pharmacists and we do run the vaccine service. I'm just wondering about the COVID vaccine actually, because this year this mention is for immunosuppressed individuals, so it's not really highlighted for chronic. So are we saying that?
I'm absolutely sure. So I will show you because I put it on that slide. I'm going to have to find it now. So basically I pulled it out. So the recommendation, I have too many slides, don't I? Never knowingly too few slides being. God. So here, this is the statement, and it says individuals aged 6 months and over who are immunosuppressed as defined by tables 3 and 4 in this chapter. Tables 3 and 4 include patients with sickle cell disease.
Because there's a section for immunosuppressed individuals, and that is more like diseases and treatments. So
no, so this is, but they say anybody who's in the immunosuppressed sections of tables 3 and 4 is. Do you think it's just the other bit? I think that they should be part of that recommendation. I can check that. I can ask the
sure.
JCVI. Apologies
Okay.
if I've got that information wrong.
Sure, thanks.
Hi, Dr. Liz. Thank you so much for this interesting session. I had a question. So this is Debbie from London Northwest Brent Sickle Cell Centre. I had a question just around yellow fever vaccine and hydroxycarbamide. So given that yellow fever is a live vaccine and it's mentioned that we should avoid giving it to patients on hydroxy because of the generalized infection that it causes, what are the current recommendations, or are there any alternatives for people who are traveling to known areas with yellow fever who are on hydroxy, who require that protection as well against yellow fever? I think she's frozen.
Sorry, Ralph, my computer crashed, so I'm just on my phone.
Oh dear.
Okay, no worries.
Sorry, I was apologizing to say I will confirm about the tables.
Okay. I don't know if you heard my question about yellow fever.
I didn't.
Oh, okay, no worries.
No.
Yes, so I was asking about, the live vaccine. So yellow fever is a live vaccine, and we have patients who are on hydroxycarbamide and they may be traveling to known areas for yellow fever. So my question is, are there any, what are the current recommendations or alternatives for those who are traveling to these areas who are on hydroxycarbamide but also need protection against yellow fever?
So that was why I would suggest that these patients who are traveling to high-risk areas are referred to the Hospital of Tropical Diseases, who are very happy to see them. So if you go to the Hospital of Tropical Diseases website, there is an email address for making referrals. And I think that it would be really valuable for these families to go and have that conversation with professionals who do this full-time as a living. If they are, I don't think that would be a reason not to give yellow fever, but they would be able to give advice about that, but also to provide an exemption certificate so that they can travel and give advice on how best to protect themselves against contracting yellow fever in terms of where they travel and wearing appropriate long sleeves, protecting from mosquito bites, etc., and using DEET appropriately. So, but I think this is where it is really important to use the appropriate teams to get the appropriate information. So if we manage to open some ad hoc clinics for travel advice in May and June, you're very welcome to refer any patients just there. I will share that information through Ralph.
Amazing, thank you.
Thanks, Debbie. Elizabeth?
Hi, thanks, Ralph. Hi, Dr. Liz. I think Debbie actually asked the question I was going to ask, but it was to say as well, we had a similar case in our cohort of paediatric patients. We've got a child traveling to a known area, Ghana, and that was the same question that they had with to us in clinic, actually, in terms of yellow fever. They presented to their GP to get the yellow fever vaccination, and they were turned away. And they're traveling in 2 weeks' time. And I think it's 10 days before they've got to have the vaccination. So yes, I will send an email to or referral to the tropical clinic, UCLH, to see if they can see them as soon as possible, just to get that advice.
Let me know if you're struggling, because Nikki, who runs the clinic, is a friend of mine, and I could give her a call and see if they can fit her in fit your patient in at the last minute.
Perfect.
Because I think this is it's a regular problem. I mean, realistically, if they're going to Ghana, they're probably not going to be traveling in a rural setting, are they?
I'm not sure. I think because their entry requirements is to present the yellow fever certificate regardless. So I guess
so we
that's
can
the
do
issue.
an exemption certificate if needs be. And I think that's where chatting. This is what. So in the clinic, we have a chat about where they're going to go if they're only traveling to a city and are visiting friends or staying in a hotel or what have you, and they're not going to be going trekking in the jungle. The risk of actually contracting yellow fever is quite low, and therefore, if there is a reason not to vaccinate, then they very happily provide an exemption certificate.
Okay, perfect. Thank you so much.
No worries. I'll put my email in the chat so that you can contact me.
Excellent, and I can forward it around after a meeting as well. Louisa.
Hi, thanks for an excellent talk. I'm Louisa. I'm an interloper and I'm from Scotland and an adult haematologist. I just wanted to add just a little bit in terms of the yellow fever. It is an interesting one because it does specifically say that it is contraindicated, but I don't think any of the haematologists believe that that is the correct decision for hydroxycarbamide, and probably something at higher level. Somebody needs to somehow get it out of the guidance that says it, because it isn't really as lymphocytotoxic, or as it's more myelotoxic and doesn't really associate with live viral infections in clinical practice.
So I'm part of a group who are updating the guidelines for immunosuppression nationally, so I can bring and this is one of the questions that comes up a lot, is about yellow fever for a variety of patients, including post-transplant, when it's safe to give, and when post-chemotherapy and all the rest of that. So I think this is something that is being looked at a national level. So I think that guidance would be useful. I think it's really difficult because for most patients who travel to yellow fever areas, they're not actually really putting themselves at risk of yellow fever. If we're, but if you think about how you actually contract it, but that doesn't mean we shouldn't protect as many people as possible. But the yellow fever vaccine is a risky one because it does have significant side effects. So it is worth making sure you get accurate information. So I'm just thinking the other tropical centre is not very valuable for Scotland, but it is Liverpool. I don't know if you have access to a tropical team for your patients.
We do have travel clinics and an ID team, so I don't know if they call themselves a tropical team, but they certainly would give advice. But I think they would give advice that would just follow the hydroxycarbamide don't give and do things accordingly. But so it is particularly because the yellow fever is more dangerous because of the other live vaccines are fine. Is that?
Yeah, so yellow fever has got more significant side effects than other live vaccines. It is more people are more likely to develop attenuated yellow fever disease. It is documented. So I think that's possibly where the caution comes in.
Fair enough.
Yeah. And I think particularly because the risk benefit isn't as clear. So for example, as it might be for measles, where your exposures are different. And I think that might be the other reason why giving an exemption certificate is a more reasonable path to take. So it all comes down to risk benefit conversations.
Perfect. Thank you.
Right.
Excellent. Are there any other questions at all? If not, I would like to thank Liz. Oh, okay. Alison.
I was going to ask just one on the same topic of live vaccines. We have the same problem with the intranasal flu vaccine we have lots of kids now on hydroxycarbamide, but all the local school nursing policies are, again, if you're on hydroxycarbamide, you can't have the live intranasal flu vaccine, and then you have the same issues with they then have to go to the GP practice, and the uptake is a lot lower for the inactivated vaccine. And it's also because we don't really discuss lots about its effect on the your immune system when we start children on it. But again, I guess the question would be, is that just someone writing a policy who's not thought it through, or is there really an increased risk for those children on hydroxycarbamide getting the flu vaccine?
So it's very interesting because we've looked at this. There's been a series of studies called FluShed and a variety of other studies looking at the safety of live attenuated influenza in immunocompromised, which have found that really it's pretty safe, even with much, I would have thought, more significant immunocompromised than hydroxycarbamide. And I wonder if this is a lack of catching up for this particular drug. And so there is actually there is a JCVI section for LAIV, and I will contact them specifically and ask them, because it does seem like I know you guys know better than I do that the population with sickle cell is increasing in the UK, isn't it? So this is an increasing problem, and they are the group we really want to protect with our vaccine. So I will see if I can get the JCVI to have a look at that.
That would be really helpful.
No worries. Interesting. If there are any other questions like that, let me know, because this is exactly the type of thing that gives me joy, is sorting out these minor problems.
Thank you. Letitia.
Hi, my question is around the Hep B vaccine. Quite a lot of my patients, the GPs refusing to give the vaccine. I haven't come across any sort of like evidence to influence that, and I just wondered if there's any changes that I'm not aware of.
Why are they refusing to give it?
Saying that they no longer provide it.
Yeah, I think this comes down to commissioning.
Right.
To be honest, and that's just really disappointing, because you would kind of think that. So we find if we ask a GP to do something as our recommendation, they normally do it. So if you write a direct letter to the GP to ask them to do it, are they still refusing?
Yes, so the hematologist did write a letter, and they have refused. So the plan is to write another letter.
Okay.
And hopefully we'll get that. But
so the other alternative is to give it to them when they come to clinic. Would you give it at a hospital?
I'm not aware of St. George's giving the vaccines, to be honest, in clinic. And Michaela could probably correct me if I'm wrong there, because I'm community-based.
But you should just be able to prescribe and give the vaccine to anyone in a hospital setting. So we certainly give it to patients here at Mary's. And it might be worth, I think obviously they should just be getting it through the GP practice. It gets uploaded properly onto the records and things like that way. But that might be an alternative if you're really struggling. I am slightly surprised at that, so I'll look into that. Because the other thing that they do give it as part of, we have young children and young people seeking asylum and refugee status who are unaccompanied, and they get the catch-up vaccination with Hep B without the GPs having a problem. So I don't know why you would exclude this population. I can have a look into that.
Thanks. And Michaela has just confirmed that they don't do it at St. George's. So
the pharmacist at the Whittington has put her hand up to tell me they won't do it either.
No, I was just wondering, I'm just going to share my screen, because I wonder, is it because it's not actually in the national guideline? It's not very apparent that Hep B is to be offered to those cohorts. So I'm just sharing my screen. I wonder if it's due to confusion.
Yeah.
So it took us a while in terms of trying to look for the recommendation that hepatitis B should be offered, and it's kind of hidden in the Green Book.
Yeah, I definitely saw it in the Green Book when I was doing some research for this, which is why I included it. But now I'm not sure where I saw it.
Yeah, so when you look at the poster from the UKHSA, it's really not very apparent in there.
Okay.
I mean, it does state it in the clinical standards for sickle cell patients. Yeah.
Yeah, and I kind of, I don't know, maybe I'm always a bit naive and optimistic, but I feel like we should be taking any opportunity to give any vaccine to anybody who wants it. I feel like there's no downside to giving people vaccines, if it's appropriate. I can also try and see who writes that poster to see whether we can get that updated. Because we have a colleague who works for UKHSA here in the vaccine cell. So let me see whether that could be updated in there, and that might help with the GPs giving it if you can direct them to a location where it's recommended.
Thank you.
No
Excellent.
worries.
So thank you everyone for asking questions, and then mainly thank you Liz for the excellent talk and for giving over your time this afternoon to update the haematology teams about the status of vaccination and how to help patients with the uptake of that.
No worries. I love talking about vaccines. All right.
Excellent.
Nice to meet you all. Take care, and apologies my computer crashed.
No worries.